It's a very intriguing question whether the new agents that are coming in and potentially disease modifying, would they change the indication for myelofibrosis and transplant? For one thing, that we don't have a clear definition of what exactly a disease modification is and how it will translate into improvement in the outcomes. Ideally, a disease modifying agent should be something that in myelofibrosis that can cause hematologic improvement, ideally hematologic remission, and some of the other things, a decrease in the malignant clone, improvement in the cytogenetic abnormalities, resolution of fibrosis, improvement in cytokine abnormalities, and finally, actually, really improving in the survival of the patient with the improved quality of life. So, the data is kind of premature with the new agent, so it's a little bit hard to predict, but it seems like where the direction is going, that the new agent is definitely going to improve the outcome of transplant, just like Ruxolitinib has done. The patient who have been on Ruxolitinib responding, for example, when they undergo transplant, they actually do much better in transplant than patients who are either not on it or do not have good response. So we know that the agent with better responses have better transplant outcomes. So we think that a good treatment for eligible patient who need transplant is going to improve the transplant outcome. What might happen is that patient, if they really have a prolonged duration of response, the indication of transplant may not exactly change, but patient may not need transplant so acutely when they need it, that potentially can be delayed and they can get benefit from the medication. And really down the road, hopefully we can improve the outcome of patient with and without the transplant.